Welcome everyone to Cardiomyopathy Part 3. In this Part 3, I will talk about hypertrophic cardiomyopathy in detail. I will start with the definition of hypertrophic cardiomyopathy. Then I will talk about etiology, pathophysiology, complications, and finally the morphology. In the olden days, hypertrophic cardiomyopathy used to be known by other names: hypertrophic obstructive cardiomyopathy and idiopathic hypertrophic subaortic stenosis. But nowadays, these two terms are not used anymore. Not all the patients with hypertrophic cardiomyopathy have obstruction. So that is why the term hypertrophic obstructive cardiomyopathy is not used anymore. The cause of hypertrophic cardiomyopathy has been known to be genetic mutations. That is why the term idiopathic hypertrophic subaortic stenosis is not used anymore. Hypertrophic cardiomyopathy is defined as asymmetric hypertrophy of myocardium of left ventricular wall and interventricular septum. So the definition says that there should be hypertrophy of myocardium of left ventricular wall and interventricular septum, and such hypertrophy is asymmetric. It is not symmetric. But this definition is not complete. To complete this definition, three conditions should be fulfilled, and these conditions are stated here. Number one, ventricular chambers should not be dilated. Number two, another cardiac disease for the hypertrophy of myocardium and septum should not be present. A systemic disease for the hypertrophy of myocardium and septum should not be present. For example, hypertension. In this slide, with the help of illustration, I am going to explain what is asymmetric septal hypertrophy. In hypertrophic cardiomyopathy, the thickness of both interventricular septum and the left ventricular wall is increased. This is interventricular septum, but the thickness of interventricular septum is more than the thickness of the left ventricular wall. And because of significant myocardial hypertrophy, the chamber size of left ventricle is decreased. You can compare the size of the chamber of left ventricle with the chamber size of right ventricle. Clinical diagnosis of hypertrophic cardiomyopathy is done by measuring the thickness of left ventricular wall with the help of echocardiography or MRI. If the thickness of left ventricular wall is 15 millimeter or more than 15 millimeter, then the diagnosis of HCM is established. HCM is not a rare disease. The prevalence rate is 1 in 500. This disease is equally common in males and females. HCM is a genetic disease. It is caused by mutations of sarcomere protein genes. The most commonly affected sarcomere protein gene is myosin protein gene. These mutations are inherited from the affected parents by autosomal dominant inheritance pattern. Some cases of HCM are caused by de novo mutations. De novo mutations are those mutations which are acquired after birth of a person. Inherited HCM is called familial HCM, and HCM caused by de novo mutations is called sporadic HCM. In the subsequent slides, I will discuss about pathophysiology of hypertrophic cardiomyopathy. The disease starts with mutations of sarcomere protein genes. Majority of patients are in stage 1. This stage is called subclinical HCM because patients do not show symptoms. They have genetic mutations but they do not show symptoms. Many patients progress to stage 2. It is called classic hypertrophic cardiomyopathy. These patients suffer from diastolic dysfunction. Left ventricular outflow tract obstruction may or may not be present. Left ventricular ejection fraction is high, and these patients have mild symptoms. In stage 3, patients have diastolic dysfunction, which is moderate to severe. Ejection fraction is in low normal range. In stage 2, the ejection fraction is high, but in stage 3, it is in low normal range. Left ventricular wall is thick in stage 2, but in stage 3, it begins to become thin. These patients suffer from left heart failure. 15 to 20% patients progress to stage 3. The final stage is stage 4. It is called end-stage HCM. Less than 5% of patients progress to stage 4. There are two variants of end-stage HCM: hypokinetic dilated and hypokinetic restrictive. In the subsequent slides, I will discuss each stage in more detail. In stage 1, patients are asymptomatic. In stage 2, which is classic hypertrophic cardiomyopathy, there is myocardial hypertrophy. Because of myocardial hypertrophy, chamber size of left ventricle is reduced and the thick myocardium becomes stiff. In this stage, myocardial fibrosis is less than 5% of total left ventricular mass. In stage 2, patients suffer from diastolic dysfunction. Impaired filling of left ventricle during diastole is called diastolic dysfunction, and diastolic dysfunction occurs because of small chamber size of left ventricle and because of impaired relaxation of thick, stiff myocardium. And the result of diastolic dysfunction is decreased end diastolic volume. Myocardium is hypercontractile in stage 2. It is hyperdynamic. Because of hypercontractility, ejection fraction of left ventricle is increased. It is more than 65%. The normal range of ejection fraction is 50 to 65%. Patients suffer from myocardial ischemia and angina chest pain, and the causes of myocardial ischemia are given here. Myocardial oxygen demand is increased because of hypertrophy of myocardium, and because of increased left ventricular pressure and because of impaired left ventricular myocardial relaxation, intramural coronary arteries and arterioles are compressed. And because of such compression, blood flow to myocardium is decreased. In addition, tunica media of coronary vasculature, coronary arteries and arterioles is increased. Because of increased thickness of tunica media, that is luminal narrowing, and that also contributes to myocardial ischemia. Left ventricular outflow tract obstruction (LVOT) occurs in 1/3 of patients of HCM, and LVOT occurs because of asymmetric hypertrophy of interventricular septum. And here in the illustration, you can see just below the aortic valve, this part of septum is disproportionately thick, and this causes narrowing of the tract, which is called ventricular outflow tract. And there is also mechanical obstruction to the blood flow from left ventricle to the aorta because of systolic anterior motion of mitral valve. The anterior leaflet of mitral valve comes into contact with the interventricular septum during systole, and such motion of anterior leaflet of mitral valve is called systolic anterior motion. So in stage 2, stroke volume and cardiac output are decreased mainly due to diastolic dysfunction. But most of the patients in this stage are clinically stable and they suffer from only mild symptoms of decreased cardiac output and increased oxygen demand. But if left ventricular outflow tract obstruction is severe, then patients can suffer from more severe symptoms. Most of the patients are present during second and third decade of life. For example, patients can present during post-pubertal growth spurt, and athletes can present during periods of exertion. 15 to 20% of patients with HCM progress to stage 3. This is the intermediate stage of disease progression. Patients have moderate to severe diastolic dysfunction. Left ventricular ejection fraction is in low normal range. In stage 2, it is high. And there is severe left atrium dilatation. Because only decreased amount of blood from left atrium can enter left ventricle. So the left atrium dilates progressively because blood accumulates in the left atrium. Atrial fibrillation can occur, and there is stagnation of blood, and that leads to thrombus formation. Because stagnation of blood is one of the three elements of varicose triad, thrombus formation can occur in dilated atrium and which has atrial fibrillation. There is progressive myocyte loss because of coronary microvascular ischemia. The myocytes die by apoptosis. And because myocardial cells cannot regenerate, these lost cells are replaced by fibrosis. So in stage 3, myocardial fibrosis accounts for more than 25% of total left ventricular mass. Because of severe loss of myocardial cells, left ventricular wall starts to become thin. In stage 1 and in stage 2, left ventricular myocardium is thick, but in stage 3, because of progressive loss of myocytes, the wall starts to become thin. In this stage, patients suffer from more severe symptoms of left ventricular failure. Pulmonary hypertension can occur because blood from lungs cannot drain into the left atrium because left atrium is already full of blood. So because of pulmonary hypertension, there is increased hydrostatic pressure in the pulmonary vasculature, and fluid extravasates from within the blood vessels into the interstitial tissue. So there will be pulmonary edema. And right ventricle in particular, has to work harder to pump blood into the lungs vasculature because there is pulmonary hypertension. So ultimately, right heart failure can occur. Mortality in this stage can range from 3 to 5% per year. Less than 5% patients with HCM progress to stage 4. This is the final stage of HCM, so that is why it is also known as end stage HCM. It has two variants. One is hypokinetic dilated form. In this variant, left ventricle is dilated and wall is thin. In stage 1, stage 2, and stage 3, the chamber size of left ventricle is small. But in stage 4, the chamber is dilated. The wall is thin, but residual foci of hypertrophy of the myocardium can be seen in this stage also. Systolic dysfunction is seen, which worsens heart failure. In the earlier stages, myocardium is hypercontractile, but in stage 4, systolic dysfunction, myocardial contractility decreases. That is the reason why ejection fraction in this stage is less than 45%, less than normal. The normal range is 50 to 65%. There is transmural fibrosis in the left ventricular wall. Myocytes are lost in big number, and these lost myocytes are replaced by fibrosis. Here you can see the black arrow is pointing to whitish area, which represent the areas of fibrosis. In the hypokinetic restrictive form, left ventricle is small and stiff. There is extreme diastolic dysfunction, and it resembles primary restrictive cardiomyopathy. Systolic function is only mildly or moderately impaired in hypokinetic restrictive form. Myocardium has significant amount of fibrosis and it is thin. There is marked biatrial dilatation. Both left atrium and right atrium are dilated. There is atrial fibrillation. So now let's recapitulate what are the mechanisms of decreased cardiac output in hypertrophic cardiomyopathy. So these are the mechanisms. In all patients, diastolic dysfunction is there. So most important and most common mechanism of decreased cardiac output in HCM is diastolic dysfunction. If diastolic dysfunction occurs because of decreased chamber size of left ventricle, and diastolic dysfunction occurs because of impaired relaxation of thick, stiff myocardium. So end result is decreased end diastolic volume in left ventricle. Left ventricular outflow tract obstruction also contributes to decreased cardiac output, but not all the patients have left ventricular outflow tract obstruction. The left ventricular outflow tract is narrow because of asymmetric septal hypertrophy. And there is also obstruction to the flow of blood from left ventricular chamber to the aorta because of systolic anterior motion of mitral valve leaflet. Now let's study the complications of HCM. Sudden death. HCM is the most common cause of sudden cardiac arrest and death in young athletes. In almost 1/3 of cases of sudden cardiac death in athletes younger than 35 years of age, the underlying cause is HCM. And these athletes die because of ventricular tachycardia and ventricular fibrillation. Ventricular tachycardia and fibrillation arise because of conduction abnormalities in myocardium. And conduction abnormalities arise in the myocardium because of myocardial ischemia, fibrosis, and myocyte disarray. Atrial fibrillation occurs because of atrial dilatation. The left atrium dilates because of impaired diastolic filling of left ventricle. So blood accumulates within the atrium, and blood stagnates in the left atrium. Stagnation of blood predisposes to thrombus formation within the chamber of left atrium. Emboli can arise from the thrombus, and thromboembolism can occur. Now, the morphological changes that occur in heart in hypertrophic cardiomyopathy. Left ventricular wall is thickened because of myocardial hypertrophy. The thick myocardium is stiff because of myocardial hypertrophy. Chamber size of left ventricle is usually decreased. In very few cases, it can be normal. Ventricular dilatation is absent, except in end-stage HCM. In the hypokinetic dilated form, the left ventricular chamber is dilated. In this photograph, you can see thickened wall of left ventricle and narrow lumen of the left ventricle. Any part of left ventricle myocardium and interventricular septum is hypertrophied, but the thickness of the interventricular septum is more than the thickness of left ventricle wall, and this is called asymmetrical septal hypertrophy. Because of asymmetrical septal hypertrophy, the heart has banana-like configuration. Anterior mitral valve leaflet is thickened. When a section of myocardial tissue is examined under the microscope, marked myocyte hypertrophy is seen. The myocardial cells are disorganized. Bundles of cardiomyocytes are arranged at perpendicular and oblique angles to each other. There is interstitial fibrosis. Depending upon the stage of HCM, the amount of fibrosis varies. Thank you. Please subscribe to the channel and give feedback in the comments